thank you again for inviting me to speak. I feel even more like a fish out of water. I think I'm way out of water in the sense that I'm not really giving an engineering talk today. It's really a clinical talk. Maybe consider this a break so you can look at some brains and feel the pain of people who work clinically with CSF disorders, which can be quite complicated, not straightforward. And I think we all know that. How do you advance? Let's see.
Use the mouse.
Use the mouse?
My question.
Okay, no disclosures. So, of course, there's many ways that pressure can be high and low. I'm really just going to focus for the most part on idiopathic intracranial hypertension and low pressure that is often caused by CSF leaks that we see quite a bit of in our clinic, in the CSF clinic. And as much very sophisticated measurements and calculations that have been done here, as a clinician, we really are relying on something that's been around for many, many, many years. And we all know it's not perfect, but yet decisions are made based on lumbar punctures and opening pressures. And decisions are made for surgery and really life and death decisions based on measuring pressure from the back. Often we know that leads us in the wrong direction. There's a lot of technical problems. Obviously, the idea of position, how the measurements are made. A lot of times you cannot perform. For example, we see a lot of patients with Chiari malformation, and you cannot perform, or anomaly, you cannot perform often a lumbar puncture in this kind of situation, or at least to take much fluid. And so also it's a single number, single time point. You can't look at pulse curves, compliances. You can't detect if there's episodic changes because you're just obviously getting one number. And in a situation where you may have more complex disorders where things are increasing and decreasing pressure, we might end up with situations which pressure is actually in the normal range, but there's still a lot of problems. So measuring one point of pressure at one time from one place when there's a lot of technical problems is obviously not sufficient. But again, this is what we most often use, at least as a starting point, often the ending point. In our clinic with CSF disorders, we've learned that we live in a web, which is, by the way, you could sit on, we do have a whiteboard, and we could draw lots of lines, and you can add more lines and more disorders. But often we'll be working up a patient we think has a CSF leak. Every time they get up, they have bad headaches and dizziness, and have maybe a history of trauma or other things that may be consistent with a CSF leak and hypotension. Yet we find out that they have a background of pseudotumor, that's idiopathic intracranial hypertension, which is causing or feeding or allowing the CSF leak to persist, even with attempts at treatment. We also can have hygromas and hematomas. We have the brain that sags, and we often see CSF leaks and Chiari malformation. So I can go on and talk about different relationships of the pressure and brain changes and mixed conditions. But these are the situations which have very different treatments, and we have to decide how we're going to approach each patient when they come to us. So I'm going to talk, to start off, just by talking about a few clinical cases. Many of these cases we don't really need ICP pressure measurement because there's something in the clinical history that tells us. But many times we do need better pressure measurement to guide us in our treatment. So here, typical patient may come to us, cognitive slowing, bad headaches, and bilateral chronic subdural hematomas. You see them around the outside here on both sides. And this is kind of classic neurosurgery in the sense that you have high pressure due to bilateral subdural hematomas and cognitive effects because of that. So you might think, well, let's drain these and relieve the pressure. Well, I think most the clinicians here know that there's some signs, even from the MRI and also from the further history, that say that these subdural hematomas are not really the cause of the problem and are not really something that we should drain, or at least drain alone. Let me see if I get to the next picture here. Oh, yeah. So this is a 50-year-old, not a very old man. He doesn't have an atrophied brain, no known trauma, and as you see here, the white lines around, he has enhanced, this is an enhanced MRI, has enhancing membranes, all indicating low intracranial pressure. So these are the subdural hygromas, and then this evolved into chronic hematomas of a low pressure situation, a low pressure problem. And if you do, and I've seen patients come to us after burr hole drainage of subdurals like this, and they just come back and they continue to be problems. It's the wrong therapy, at least in isolation, because it's not treating the problem. In this case, you wouldn't need ICP measurement to tell you that. You hopefully would not do the burr hole drainage alone. In this case, we did we put a blood patch in the lumbar spine and did a repair of a CSF leak. And then he developed bona fide pressure symptoms. And we did end up doing burr hole drainages and releasing this. So he required a patching from below and then a release from above. So in this case, a two-staged operation from that. It could be done at one time. But you need both levels of treatment in order to help this gentleman. Here's a person, I believe he was in his 40s or 50s, active man, professional, who had pseudotumor cerebri. And he was on diamoxin, somewhat controlled, moderately controlled now. He had a reduction in his headaches. He was moving his daughter, and then he was playing handball when he had increase in headaches. While he was playing handball, he felt a twinge in his back, severe pain, and then over the next 12 to 24 hours, severe headaches. Well, when he was seeing an image, you can see the images here of the MRI, and I'll show you other CTs next. But you see again, subdural hygromas. And you see a lot here that indicates different CSF abnormalities. You can note the empty cellar, the CSF in the cellar region. There may be some posterior migration of the brainstem downward. That's very slight. If you measure from the top of the posterior clinoid up to the top of the tent, the aqueduct here is behind that. That's by some an indication of some migration backwards. So we see indication of pressure probably from the subdural hygromas, which eventually, of course, also evolved into subdural hematomas on both sides. So here's a person who had high pressure, had a sudden event of some kind, which could have been the bleed, actually. Well, the bleed actually occurred afterwards, so it wasn't exactly the bleed, but he had a severe pain in the back, has a situation which looks like low pressure, CSF leaks, as well. So we have probably some sort of mixed problem. Well, the first thing that was done was to look at the spine. I think I have the next. This is treatment, and let me go on. We looked at the spine through CT myelography, saw areas that were suspicious for CSF leaks, and I'll show a little bit more detail of that later. And treated those, well, attempted to treat those first, but the pressures in the spine were so high, presumably because of the subdurals. I went in and just evacuated the subdurals. We also put in a pressure monitor at that time, and subsequently went back and did the targeted blood patches, and I'll show you an example of that, to seal off the CSF leaks. The CSF leaks are really amazing because they're hard to find. They're intermittent, episodic drainage, and a simple myelogram might miss it because you might not see the blood, the gadolinium or the or contrast egress because it's either out before you do the image or it doesn't leak during the image. So we have a system, it's called dynamic CT, in which you have the patient right on the CT table, you inject fluid, increase the pressure, elicit a leak. And here you see a leak that was treated and eliminated, and there was a smaller one, I think, on this side as well. So these are targeted fibrin glue and blood patches, which we use to try and seal up CSF leaks. We put the monitor in to see if, when the patient got up again, if we really had the effect that we wanted. In other words, when he got up, did his pressure go down into low levels, indicating a CSF leak? Here's a patient, and this is common since we see quite a few patients with Chiari as well. 40-year-old female who also has shunted pseudotumor. As I think many of you know, pseudotumor cerebri, increased intracranial pressure, is more common in patients with Chiari formation. A relatively large woman, Chiari malformation, and this was actually done by other surgeons. She had 2 failed attempts at Chiari decompression. She had residual, she has a shunt in here, she had residual posterior headaches, and as you can see, a pretty significant compression, loss of CSF spaces, and deformation of the tonsils at the level of the Chiari. This is where she had her pain. It was definitely due to the Chiari, and I was considering, well, maybe she does need a Chiari decompression. However, there's one other thing I didn't say, and that is she has a LP shunt, which was also used in the treatment of the pseudotumor, because it's hard to drain fluid from those little ventricles consistently, and someone tried also from below. When I ligated that LP shunt, the Chiari essentially went away over several months, as did her headache. Another case in which a Chiari decompression would not have solved the essential problem. Here, not because of a spontaneous CSF leak, but because one that the neurosurgeons really caused initially or previously. Another example, I think, an interesting example of a failed Chiari decompression. This is a 30-year-old female that came to the neurologist. She had a long history of headache and surgery. She comes to us now with occasional headaches, right arm numbness, and some two episodes of bowel control loss. So something's going on, but actually she was doing quite well, and she was asking if perhaps she might be able to get pregnant, if that was safe. So here's her MRI sagittal from about 10 years ago, and you see there's a Chiari and a Chiari decompression. She, in fact, had 2 Chiari decompressions, which did not, at least entirely, remove her symptoms. She also had a pituitary biopsy and resection for a swollen, what they perceived as a swollen pituitary gland. So, interesting history, 10 years ago, 3 operations, and here's a Chiari decompression. Can she get pregnant, and are these symptoms something we should be concerned about? I was at first thinking, well, maybe she needs a duroplasty or cranioplasty for some support. It's quite a wide decompression. Then she got an MRI, and you can see her now. Her brain is practically falling out of the bottom of her skull here. It's also herniated downward into the infratentorial region. There's tentorial herniation. You see tissue on the side here. So she has quite a dramatic response over time to what turned out to be another CSF leak, which was chronically there and missed. The pituitary swollen pituitary that was seen and operated on was very likely due to decreased intracranial pressure. Chiari malformation, as we all know with the brain sagging, is also a sign. But there was no enhancement of the meninges. There were not the other signs. When patients come to us with a Chiari, we automatically think of it as a Chiari and not necessarily an acquired Chiari or anomaly, which may be due to things like fluid leaks or shunting. So here's another situation. The first Chiari decompression, the second Chiari decompression, if I did a cranioplasty, those all would have been not the proper operations, because what she really has is a CSF leak causing low pressures and a pressure inequality, which can only be treated by dressing it exactly. This is it, just a bit larger, and you see the herniation coming down each side. There is, actually on this MRI, she does have some enhancement as well. So the treatment was to do patching of the occult spinal leak. This is a patient, yes, another Chiari patient, female presenting with generalized severe headache. She also, and it's a pretty tight Chiari, as you can see, and of course there's a syrinx. She had some episodic numbness of her arms as well, but no other deficits in the extremities. She also, however, significantly again, had papilledema. She was not a very large person, but on imaging was found to have bilateral transverse sinus blockage. So we have evidence now of higher venous pressure and probably a pseudotumor cerebri, and also, of course, Chiari with syrinx. Because she had this pseudotumor cerebri and the sinus blockages, we did the stenting first to open up the posterior veins and decrease the intracranial pressure and relieve the pseudotumor or intracranial hypertension. Here you see, this is all we've done between these pictures. You see that the Chiari is at least a little bit less than it is, and there's CSF spaces that are there now. And the syrinx has declined as well. And actually, this was taken just 1 or 2 months after the surgery, and she continues to do well and has no more symptoms from Chiari or syrinx. We're watching, of course, to see how this evolves over time, but this is a patient whose essential syrinx was treated through stenting of the transverse sinuses because of the indirect path of its cause. So the basic clinical lesson of these cases is that we better know what the pressure is and be ready to look and treat high pressures or low pressures in diseases where they can cause things like subdural hematomas and hygromas and Chiari malformations. Because if you don't, you'll get some of the things that you've seen in the previous slides. So these are, of course, important decisions for that reason. Also, there's a more common reason that we often look at LPs and look at pressures. Shunt placement. If you don't get reliable pressure information, then you may be doing shunts and multiple shunt revisions when there isn't a pressure problem. I mean, these are the obvious reasons to get pressure measurements. And again, we depend on something which is, I think, quite inadequate, and that's just a lumbar puncture. Even if it's done, we feel, in the right way by us, it can have artifacts. You can also do multiple procedures to identify or treat a CSF leak when the pressure is normal. We've had patients come to us who have had over 10 blood patches, some of them targeted. They've had myelograms, they've had procedures, and been to multiple hospitals. We took a step back and said, do you have high pressure? Do you have low pressure? Now, one way you could determine that, of course, is the LP, but the LP in a person who's horizontal can show pressures really in the normal range. There's some people that have a number of less than 6 on an LP means your pressure is on the low side, but there's not really any good data about that, about sensitivity. So identifying people who truly have low CSF pressures can be very difficult to do with an LP, and we need better data in order to decide if we should still be pursuing CSF leaks. So often, as you saw from the previous slides, clinical presentations can help us, and LP, if it's very high, for example, may be able to help us. But in the case of, for example, pseudotumor, but these can also be misleading. These are the signs that we've kind of gone through in the previous slides. A decrease in the brainstem position here, a swollen pituitary, hydromas, Chiari malformation, sometimes enlarged venous sinuses and so forth. All these are signs of low pressure, but all of these have quite a low sensitivity and don't exist in all the patients. And unfortunately, CSF leak detection, also a series of studies, many of them invasive, is also suffering a fairly low detection rate. So that's why we need some ICP monitoring to really take a step back and see if these patients have low pressure to make a decision. In this study, and this is really a preliminary look at data that we use, we've used more ICP monitoring, more and more, in order to help us guide the treatment in these patients. And they come in basically the two groups of the high pressure patients. Some of them actually, of course, slip ventricle syndrome is another situation. But if there's no definitive papilledema, or if their LPs from the past are marginal, which is to say marginal in the sense that their technique might have been suboptimal, or we don't know it, or also if the pressures are within the 20s or not in a high normal range, then we don't know if they need their shunt revised or if they need a shunt at all. And we need better pressure information. In the case of the CSF leaks, clinical suspicion of a hypotension is with positional headaches, and there are other symptoms, of course, that can go along with that. No definitive MRI signs, in other words, no sagging, no definitive CSF leak on a normal MRI. However, they may have a Chiari malformation, that's sometimes how they present to us. So these patients are patients in which we may need much more information to decide if they truly have a CSF leak, because it's hard to identify them otherwise. We have a protocol at the hospital for when we use ICP, and you can see there's also a protocol for looking at the CSF leaks more generally in this case. Let me show you another case. This is a 50-year-old female with positional headaches following thyroid surgery with a hyperextension of the neck. So you can see she has a Chiari malformation, and often we might think that the Chiari was exacerbated or irritated by the surgery and the position. She also has a possible cause. She has a supracerebellar cyst with some pushing downward, so this could be considered maybe she was at risk. Had this was asymptomatic until the time of the surgery, and we should do a Chiari decompression. There is and no one really had read anything, but you might say that there's some enhancement of meninges, but it was not read, and it really would not be called. The MRI showed the Chiari, the supracellular cyst, and some incidental spinal perineural cysts, because we do screen with imaging as well. So in this case, we were suspicious of a spinal to do the patching, to do the dynamic CT myelogram, find the CSF leaks, and also treat them. That was the treatment she needed. The questions in the study that we did, and I'll go over this in about 2 minutes, is how do LPs compare with our new ICP monitoring, and do they refute or confirm the LP pressures, and does changing in position does it give us additional information in terms of CSF leaks? So the design was to take those patients, and in 70 ICP monitorings, we found 28 that had enough reliable LP data documented, and reliable documented positional data. The clinical groups were those clinical statistics groups. We did ICP monitoring, placed a Codman mini bolt in, and did monitoring for 2 to 3 days, and did positional testing. We found that generally there was great variability in the LP and the ICP monitoring data between patients, and there was no general group difference between LP pressures that were found in the ICP monitoring. Generally, however, the ICP monitoring is the lower line here. In most cases, the LP pressures were higher, but those differences also were not significantly different than 0. This, I think, is one of the more important graphs in the finding. It shows that the lying overnight average of ICP monitoring compared to the opening pressure of an LP. And there was a weak correlation here, 0.127, so no correlation. Wide variety as well. If you draw an identity line here, you'll note that 8 patients that the LP was generally higher findings than the monitoring patients. Only 8 patients had monitoring which was below the line, whereas 20 patients had higher LPs than ICP monitoring. And if you draw the lines of normality, this being conservative at 25 centimeters of water, you'll find that there are 6 patients that would have been called abnormal based on the LP, but only 1 patient was confirmed on the ICP monitoring. So there would be a good proportion of patients that would be considered abnormal and possibly operated on because of the LP pressures alone. Here's quickly the positional data showed what we kind of expect, that is decreased pressure with lying going to sitting and sitting going to standing, being more vertical, having lower pressures, and the ones that were suspicious for a leak had lower pressures, although they on average did not go below -4 millimeters of mercury. So this looked like kind of what was expected. When you look at the actual patterns, I'm going to skip this, that there's quite a variability in the pattern of decrease. Many patients unsuspectedly stayed very even when they were lying down, sitting, or standing up, whereas some patients showed what may be the more expected great decline. And I suspect there's some data that we should be getting about brain compliance and the dynamics of their CSF spaces based on the pattern between lying, sitting, and standing. We're just starting to analyze that. That's why this is preliminary. Here it is in the suspected CSF leak patients. As you see, some patients did have a normal decline, but there's lots of patients who had an up between lying and sitting. And obviously there's many physiological reasons to have pressures that go up that may relate to venous return and venous pressures in the brain, and not so much to any CSF column per se. So there's a lot of factors relating to intracranial pressure in the head, and here we see situations of flat when you go from lying to standing, of going down as you might expect, and also of going down and up. These are variables that we need to understand better, because through ICP monitoring and putting people in different positions, we might be able to distinguish the hydrodynamics better. Finally, in summary, 6 patients with elevated LP opening pressures were found. There was only 1 in the same group with ICP monitoring, and 3 out of 11 patients were found to have significantly lower CSF pressure, but only found when sitting or standing. And many times we measure pressure horizontal. I think with the ICP monitoring, it gives us the opportunity to do various provocative tests, but also to do the different positions in a systematic way. And I think we will be finding more patients who have low pressures that are only revealed with the standing position. So ICP monitoring is most useful in stopping unneeded interventions for pseudotumor. Most of the time we did this operation, we found out that, I know you've had 10 patches and you think you have low pressure when you stand up, but your pressure is fine. Or we found patients who had lingering headaches and pseudotumor and they did not have high pressure. So we use it to a great extent to rule out further operations, which is a benefit in itself. But it also will help us, and I hope more so in the future, help us find pressure abnormalities that may be more subtle and may be more complex in the different positions. One paper in the literature also showed the same sort of changes, and I'll conclude. Thank you.
Thank you very much. So, in fact, I'm wondering, we've done all this engineering, and you work so much with engineers. Is there anything you've ever done that affect what you do clinically? I mean, really, is there? Well, and if not, if so, I mean, I think in cardiovascular, it's happened, right? Engineers have translated.
In the short term, I would say no, although in terms of the thinking, the way we look at the problems, I'm sure it has had an influence. But it's had, I think, in terms of pressure measurement, for example, most people still do most of it is getting monitoring and doing laying down or a few tests, and that's about it. Still, the methods are pretty crude. I think the impact has been in imaging, but not personally, that I think we've done so. Yeah.
I think your question is to find with MRI tools to point hypo pressure. So if it's correct that hypo pressure link compliance, hypo pressure we will have a low compliance. You see, just to check the amplitude of the CSF oscillation in the spinal canal will help you to distinguish patients with low pressure and patients with very high pressure. Because with our experience, when we have a low pressure CSF oscillation in the spinal canal are quite visible.
So if by that you mean, for example, if we could do an LP, routinely but have it show time resolution and the amplitude curve as opposed to the number, which is usually all we get from LP, then I think that a measurement like that that shows pulsatility, if that did show greater compliance, yeah, that might be a tool.
A big link between amplitude of ICP or CSF oscillation with
that would be a practical tool since LPs are done routinely. The other thing that we really need is to find better ways of finding the leak in imaging besides the standard sagging brain and engorged pituitary, for example. So we need ways to see through dynamics like the CSF or brain stress or something to be able to say that this brain is under negative pressure right now. Yep. 1 second. Luciano was first.
Yeah, okay. As clinician, you know very well the difference between leakage from cranial space and from spinal space. So, the spinal has very hard clinical picture. So, is it better to apply the patient for the patient with the Pseudotumor or LP shunt, because LP shunt imitated the normal, the pathological spinal.
So you're asking about LP versus ventricular shunting in Subdural. Well, I think we have better control and better drainage and longevity for multiple reasons. I think the ventricular shunt is preferable to Pseudotumor. I'm sure that's the general opinion. I've done a lot of lumbar shunting in the past, but now that we have better guidance systems that allow us to get right in the target zone, the magnetic navigation, so forth, I definitely prefer the ventricular drainage. So, last question.
Yeah. So I was really impressed by the different positions and how it would change the pressure measured by, the LP. But if we could do that with MRI, wouldn't that be wonderful? And I don't think we can measure pressure. We can measure velocity, but then the question is, can we change the height? We can't really stand the patient up the MRI scanner, but we can raise the head and lower the thorax. We can raise just pillows raising the body, but the coils can be raised and lower if you're imaging at the same location. If you had maybe a 2 to 3 centimeter difference shift in height and then measured difference in pulse heights, I just wonder whether that might give, you're looking for a biometric marker,
Yeah,
measurements.
so I think the ICP monitoring gives us this ability to change positions, but we really need a non-invasive way. So yeah, one of these was the last.
Sort of a poor
let's find a
man's approach.
non-invasive.
Right, yeah, poor man's approach,
Or
and
at least a
MR scanner might be
non-invasive approach.
tried. Anyway, I might give it to a postdoc.
That'd be great.
Yeah.
All right, thank you very
Thank
much.
you.
Thanks to all speakers.